Assalamualaikum warahmatullahi wabarakatuh, and a very good morning to the all consultants, specialists and all my friends. Today I would like to present regarding the management of COVID-19 in O&G department in our hospital. First of all, we go to the case definition of COVID-19. Regarding the case definition, I divided it into 4 categories. The first one is suspected case of COVID-19, which is a person who meets the clinical and epidemiological criteria. First, we go to the clinical criteria. What is the clinical criteria? In the absence of more likely diagnosis, at least 2 of these following should be the clinical criteria, which is fever, chills, rigors, myalgia, headache, sore throat, nausea or vomiting, diarrhea and fatigue. These criteria should include at least 2 of the following symptoms or any of the following symptoms: cough, shortness of breath, difficulty in breathing, sudden new onset of anosmia, which is loss of smell, or sudden new onset of ageusia, which is loss of taste, or severe respiratory illness with at least one of the following, which is clinical evidence of pneumonia or ARDS, acute respiratory distress syndrome. This is the clinical criteria. And this is the epidemiological criteria, which is attended an event or area associated with non-COVID-19 cluster or red zone, or travel to or reside in a foreign country within 14 days before the onset of illness, or close contact to a confirmed case of COVID-19 within 14 days before onset of illness. What is the close contact? It can be defined as healthcare associated exposure without appropriate PPE, which including providing direct care for COVID-19 patient, working with healthcare worker infected with COVID-19, visiting patient or staying in the same close environment of a COVID-19 patient. Besides that, working together in close proximity or sharing the same classroom environment with a COVID-19 patient, and also traveling together with COVID-19 patient in any kind of COVID, and also living in the same household as a COVID-19 patient. This is the close contact. Second one is probable case of COVID-19, which is a person with RTK antigen positive awaiting for RT-PCR confirmation, or a suspect case with chest imaging showing findings suggestive of COVID-19 disease. We need to take notes regarding the chest X-ray. Radiological image procedure is not indicated in all suspected COVID-19 unless there is clinical suspicion of pneumonia. So we are not frequently do the chest X-ray for all the COVID-19 patient unless the patient show any signs and symptoms of pneumonia, such as cough, shortness of breath, and also associated with fever. The third one is confirmed case of COVID-19, which is a person with laboratory confirmation of infection with the COVID-19, irrespective of clinical signs and symptoms. And the fourth one is person under surveillance, PUS, for COVID-19, which is a symptomatic individual subjected to home surveillance order, HSO. Okay, regarding the 4 definition that I give you, I didn't talk about the PUI. Currently, we didn't use the word PUI anymore. In view of we already use the terms of probable or suspected COVID-19. Now we go to the management of pregnant woman who is COVID-19 patient or suspected COVID-19 or probable COVID-19 in our hospital setting. This also include the non-pregnant woman, which is gynae case or oncological case. When the patient came to PHC, we should decide whether the patient is in labor or not in labor. If the patient not in labor, we should refer them to the ID team, and the patient should be admitted in I ward if the patient is stable. If the patient is not stable, we should admit the patient in the ICU. Whereas if the patient came in labor, we should inform the ID team, and then the delivery should be done in trauma OT via cesarean section. While preparing the patient for cesarean section, we should also refer patient to NS team, and also we should refer to the pediatric teams. For this kind of patient, I mean COVID-19.
Assalamualaikum warahmatullahi wabarakatuh. Bacaan A'udzubillahi minasyaitonirrajim. Bismillahirrahmanirrahim. Alhamdulillahirabbil alamin wassalatu wassalamu ala asyrafil mursalin.
Okay, I continue again. We go back. If the patient in labor versus the patient is COVID-19 patient, suspected or probable of COVID-19 patient, we should inform the ID, and while waiting for the patient for seizure, which should be done in trauma OT, we should refer to NS team, we should refer to pediatric teams. These pediatric teams, we should alert their COVID team, not from the NICU team. And also we should inform the transfusion specialist that we are having this kind of patient, because during cesarean section in trauma OT, we didn't requested for GSH. If the blood need to be transfused, they will provide us the safe O. And then after the cesarean section, the patient and also the baby will admitted to I ward. This I'm talking about the laboring mother. If the patient is gynae team that need to do the urgent operation, the flow are also same, which should be done in trauma OT. But we didn't no need to refer to pediatric teams only lah. Meanwhile, while waiting before sending patient to trauma OT, we should manage patient in Cempaka room. Okay. Before we sending the patient to trauma OT, we should alert also the keselamatan, so that they can block the all the passage to the trauma OT. Sorry, before that, I would like to clear about one thing also. Currently, the new protocol, we no need to carbolize the passage to the trauma OT. We just carbolize the OT and also the bilik cembaka. Now, we are going for the management of pregnant woman who is patient under surveillance in our hospital setting. Okay, if this kind of patient came to our PAC, we should see the patient in the bilik cempaka or labor room 10. We should get all the information from the patient. If any doubt about the patient status, we can clarify back with the ID team. As I mentioned before, we see whether the patient is in labor or not in labor. If the patient not in labor, if the ward admission, if we want to admit the patient in the ward, we should discuss with the specialist who is COVID specialist, and we should treat the PCR if the patient admitted in the ward. Okay, if the patient had sign and symptom of labor, whereas no swab been taken, we should take the RTK antigen. Okay, if the RTK antigen is detected, we should treat the patient as a probable case COVID-19. Then we need to refer the patient to the ID team. Meanwhile, we should take the PCR for this patient. If the PCR came back as negative, then this patient not more labeled as probable case. Whereas if the RTK antigen is not detected or still pending, we should treat this patient as a patient under surveillance. Okay. If the patient under surveillance, we should see whether the patient is in active phase of labor or in latent phase of labor. If the patient is in latent phase of labor, if the patient is low risk, we can discharge the patient first, but we should alert our specialist before discharging the patient. If the patient had comorbids or high risk patient, we can admit the patient in isolation ward 2A. Once the patient goes into active phase of labor, we should deliver the patient in the ward 2A. Okay. When the patient is safe in the labor room 10 or in bilik cempaka already came with active phase of labor, they should be treated in that room, and then we should see the progression of the patient. This patient should be treated as a normal patient and has a low threshold for cesarean section. If the cesarean section need, we can do the cesarean section in the MOT. Okay, and then we can treat the patient postnatal in the ward isolation 2A. If the patient just now doesn't need the cesarean section and has a low risk, we can discharge the patient from the bilik cempaka or labor room 6 as a low risk discharge, and we should alert the nearest KK about the discharging the patient. If the patient in high risk case, we should admit the patient in isolation room 2A. This flowchart, we get the reference from the Garis Panduan COVID-19 Kementerian Kesihatan Malaysia. These are the additional information for the PUS. For the pediatric teams, for the case that need pediatric referral, need to refer the case to the pediatric MO in NICU, not the COVID team. This we need to know. And for anesthesiology, for the PUS cases, need to inform NSMO who is in charge emergency MOT after O&G COVID team done for assessment for them so that they can be aware. All the by right, this is from our meeting with NS and also with pediatric teams. NS team want to know whether so that they can prepare earlier. During the office hour, once had PUS case for cesarean section, the active case need to be hold until the PUS case finish due to preparation if had another emergency cases that can come from the wards or from the PHC or from the labor room itself. During the cesarean section, NS we give only spinal regional anesthesia without intrathecal morphine due to avoid complication as NS team unable to monitor patient closely. Okay, for our O&G setting, the management of POS in Ward 2A or in bilik cempaka or in labor room 10 as normal delivery. Okay, pitocin can be used using the current protocol even in 2A or in bilik cempaka without the continuous tracing of CTG. We also can do the artificial rupture of membrane once patient already in active phase of labor. The patient who require pitocin should have continuous CTG with every 1 to 2 hours. Intermittent tracing depends on patient progression. This should be case to case basis and should be discussed with the specialist. And also for after the seizure in MOT, only we need to carbolize the MOT that been used. No need to carbolize the whole MOT. This already been discussed with the Dr. Rohani from infection control. Now we proceed with the patient screening form. Actually, we still use the similar screening form, but I added a few details and we can use this form. I think this form already been photocopied by our matron. Okay, this screening form been divided into two parts. In part A, which the clinical symptoms that I've been present to you earlier. And this the part B, where I want to emphasize regarding the red zone. Patient from the red zone or patient just come back from the red zone. Okay, if the answer is yes, we should go more into details where from the which district and which mukim the patient came back, and we should know put the date where the patient come back from this red zone area. The rest are still the same. Just if the patient had been to the overseas, this I think need to change within the 14 days as well. Okay, this is the criteria for take the COVID test. Okay, for the procedure, for the all the elective general section or others elective procedures, we should take the RT-PCR for all these kind of patients. For the emergency general section or any emergency cases, we should take the RTK antigen test. No need to take the PCR. For the cases or antenatal admission, including induction of labor or ECV, no need to take any RTK antigen unless they scan positive to the epidemiological or clinical risk factor. For the spontaneous labor anticipated, also no need to take any RTK antigen unless if we think the patient will goes into the cesarean section, we can take the RTK antigen. These are from the Department of Health and Human Service Directorate Clinical Guidance and Resource of COVID-19. Okay, regarding the red zone, we can use this website to clarify in the detail from the which district and also which mukim the patient came. This also yes.
Okay, so while we are treating patient from red zone without any epidemiology, without any symptoms, as a PMS.
Sorry again.
Okay. And now what we are doing so far, those who come from red zone, we treat as PMS.
Yes.
Because we think that those who are from red zone, they should be at the HSO.
Yes.
Yeah. But from your explanation just now, not everybody from red zone falls under HSO. Means not everybody from red zone is PMS.
No. Actually, it's like this. Once our government said the place is red zone, suppose they all need HSO. Red zone or PKPB means they cannot go out from the zone unless they got permission. Okay. To give the HSO, this need to given by the Inspector Kesihatan. Okay. They need to give all the form. Okay. And also they give the band, wristband. Okay. But once they already, if the population is 100,000 for that district itself, how this IK want to give all to the people there? That's why they made the place is red zone, so that they no need to give the risk band or the HSO form to all the people who live in the red zone.
Means all red zone people are
PUS.
PUS and fall under HSO.
Yes. The reason they didn't give all the form or the wristband due to the already goes into community. They think this community already in danger to infect other people.
Okay, Jalan, understood. Thank you.
Okay. Is there any other question?
Ya, Jalal, ada soalan.
Ya, Datuk.
Soalan ni. Pertamanya, regarding the breastfeeding policy for COVID patient. Kita ada tak jabatan kita? Kalau tak ada,
Okey,
kalau tak ada kita kena adakan in document lah. Sekarang ni cuba you terang kepada kita orang tentang the breastfeeding policy ni. Macam mana?
Datuk, for breast feeding policy, so far kita tak ada untuk COVID patient lagi actually. Cuma kalau for COVID patient, they will separate the mother and also the child for COVID positive.
Okay.
For suspected, for probable or PUS, they are still giving breastfeed to the child.
Then
Even,
child tu
I'm
macam mana?
asked-
Child tu dia orang swab tak?
Child,
Jadi,
kalau if PUS, they didn't swab the child. For suspected, they're still waiting for the PCR, as well as for probable, they're waiting for the PCR.
Okay. So breastfeeding is not
Evidence for
contraindicated
patient.
in COVID patient
Yes.
lah. Okay, nombor dua.
Yes.
Nombor dua, I mentioned regarding the possibility of increasing number of patient coming tau from outside kan, deliver in our hospital. Kita kena bersedia kemungkinan surge in the number of cases lah. Tahu. In case katakan ward di Blok I Hsbas Hospital Lustar tu dah penuh semua, kita kena ada contingency plan kat mana patient ni kita nak hantar. Ada tak plan kita tu kalau in case tiba-tiba ada kes yang banyak tu untuk patient ni?
Okay, for example, if a surge of patient in our department, I do suggest we still use the Ward 2A. We just expand the place. We just use the Ward 2A is our PUS COVID patient.
Okay, I setuju that. So meaning that kita akan gunakan ni lah Ward 2A lah. Cuma kalau katakan Ward 2A penuh, then only kita probably have to send somewhere else lah, macam kalau Nerang Hospital lah. So for time being kita masih boleh cope dengan number, and I think maybe insyaAllah harap tak banyak sangat case for this year lah. So kita nak gunakan still gunakan Ward 2A as a COVID ward lah.
Yes.
Macam tu lah. Okay.